Who are we training this time, David?
Me. Now you've got your hands really full now, Roland. So I wanted to just illustrate a few things. Herchan, I can't really see the, yeah, okay. So you can see the image, guys, in England. Can you see?
We can, yes.
All right. So there was some really quite interesting at the start. We'll go back to it at the end, in that I was kind of merrily continuing. And this gentleman's a guy who in 2009, I think, had a rectum cancer. He was operated, had a left hemicolectomy. So that's why I chose this case, as you can probably imagine. I think, yeah, because we're already now, as you can see, probably at the splenic flexure. As you can see, the scope I'm now using is quite a lot longer than the scopes that the others were using, and it's a pediatric colonoscope. I have to say, another difference of me doing a lot of therapy in my life, I'm very used to and very comfortable with using pediatric colonoscopes for everything that I do. And I don't do that here because we don't have enough of them, but I probably would if I had the chance. And why is that? Because they offer a degree of maneuverability that is just not possible with an adult scope. Of course, they also offer lots of loops, lots more loops potentially than an adult scope.
Yeah, no, I just a word of caution here, if you don't mind. I mean, this is a potentially dangerous thing to do, so I think people need to approach this with caution and be very careful. And if it doesn't seem to be working, they should bail out early. They should do the easy ones
Very
first.
important.
And I must emphasise, if the patient's in pain, then you've got to desist. One other point I'd make on the safety is when you come to straighten the scope out, do it very slowly.
What do you think about a cap for getting in the ileo-caecal valve before we come to that other polyp, which I think is interesting? You think it helps you get in?
No,
you don't need it?
I mentioned that I think I did with Anita. I think if you've got a device, it helps. And one of my colleagues actually, he just has a biopsy forceps just 2 millimeters out to try and catch the fold sometimes. Again, something you need.
Can help him.
Can I just go back to the retroflexion? So one other thing I do is I'm very keen these days, David, on taking lots of photographs. So what I will do if I can is I will come back as far sort of distally into the colon as I can in the retroflex view. And I sometimes get into the mid-transverse and then slowly go back in again. And I might take 4 or 5 pictures at various junctions, at various levels as I'm coming back. I think that's really important. And the views you get on the other side of the folds are just incredible, really. And the number of times I've seen polyps on the other side of the fold in a retroflex view, and I have no sign of them in this position. I mean, it's just in hundreds.
Yeah, I totally agree with that. Yeah.
Trials sort of confirm our experience, don't they?
Yeah, indeed, absolutely. So this just demonstrates how spasms of the wall of the bowel can make you lose polyps. Maybe it demonstrates why, in fact, when you're going in, you should remove polyps rather than waiting to come back and look for them later. But there was a polyp around here. Do we agree with that?
I thought it was in the secant, David.
I'm pretty sure it was here. Is that it? Yeah. So how subtle is that? And I think that this is now TXI as another texture imaging mode from Olympus, but let's just look at MBI. I mean, permit me a little divergence from the course of basic colonoscopy to just talk about basic polypectomy, which of course is very linked to basic colonoscopy. But here, yeah, we have, how big is this, Linda?
Like 1, maximum 2 millimeters.
Oh, it's definitely 2 millimeters. Now, so how big is that cap on the scope?
It's bigger than. No,
it's about 13 millimeters. That's cap. So what is now? What do you think it is?
6 or 7.
Yeah, probably 6 or 7. You agree with that, John? 6 or 7 millimeters in size.
Over 6, maybe. Yeah.
And so, what are you going to use to remove that, Lynn?
Cold snare.
Why a cold snare?
Because it's under 1 centimeter.
And that's what the ESG says to do. So that's what I'm going to do. But why?
Because it's
because it's safe.
You have less risk of bleeding.
Right. And
you can get a little.
What about the efficacy? The efficacy is important. What if it was only safe but not efficacious? We wouldn't do it. Would we?
Mm-hmm.
So is it efficacious?
Yes, that's why we do it.
So it's of equal efficacy is what you want to say. And so what about technique? So you just tell me how to do this diminutive polypectomy here. So I've hit the polyp, that's a negative start. Okay, open the snare, please. So is this a good position? So I've got my polyp in the snare, right? Hold the scope down. So is that fine?
Just
what's the problem?
show the tip.
Yeah, show. I can't see. So that's a good important point.
So you need to know if the polyp has a nice little border. So you have
border of normal. So now it's got a border of normal. So is that a good position?
Yeah, could be a good.
What's the problem? If I close that, do you think it's going to close around the polyp?
No, it will glide off.
So I need to push out a bit, maybe. So really get some pressure on it. Really see the fried egg in the center, right? So the yolk's in the center, the white's on the outside. Aspirate a bit, right? Okay. Bit of aspiration, let it come in. And with cold snare, you don't need to aspirate so much, actually. And now close.
Yeah.
Okay. You happy with that?
Yeah.
Okay. What's going to make me say cut to the nurse? Sometimes the nurse does her own thing. In fact, with this nurse, you occasionally find that that's. I'm only joking, right? But seriously though, what do you need to check mobility or anything with cold snare, or can you just cut it off?
With this kind of polyp, I think you can just cut it.
You just need to have the piece that you want, so that's what you need to confirm. All right, and now what do you think about this cold snare defect, or just suction the thing? I think we had the polyp in the. Oh, it's a polyp. So can you see adequately here whether I've got the whole thing or not?
No.
Okay. So you can either put it fully underwater, which will also be better. So we can look at the margins pretty closely. If you're not sure, you can use near focus if your scope has it. You really beautifully see whether you have it or not. And what do you think? Do we have it?
I think that's okay. We have it.
John, do you think we have
like normal mucosa all around?
Probably right side, David. Right side. You've got not all of it. Top.
Yeah, I think we do, but of course, let's just demonstrate it, right? If you're not sure what's going on in cold snare, it's a great technique because you just take another piece off. What about glaucoma?
Well, I'm pleased you asked me that, David.
I serve the ball, you hit it down.
Just hit this one out the park. So the medics on the call here. There are two types of glaucoma. There's something called acute angle glaucoma, and there's open angle glaucoma. Now, most people who have got glaucoma and take their drops have something called open angle glaucoma, and actually Buscopan has no effect on those individuals. So if the patient tells you they're on eye drops for glaucoma, it's perfectly safe to use Buscopan. If the patient has acute angle glaucoma, they've either have it and are unaware of it, or they've had it and have had treatment, and the treatment is surgical intervention. Now, if you've had surgical intervention for your acute angle glaucoma, again, Buscopan has no effect. So the only people that you have to worry about are those who have glaucoma but don't know it yet, and those are the people who've got undiagnosed acute angle glaucoma. And in those people, they present with a painful red eye after the administration of Buscopan. So in short, you don't have to worry about glaucoma, you just give the drug. What you have to do in the recovery area is to make sure the nurse is aware that if the patient starts to complain of a painful red eye, Buscopan may have precipitated acute angle glaucoma. And for everyone else, they just get the Buscopan.
So here we have a difficult problem. One, what do we think this is? And two, how extensive is it? And three, well, how are we going to manage it, given that we have no space to work in? We certainly can't retroflex. Yeah, John, I'll give you the floor, and then I can say what I think.
This is what been at the edge of his surgical resection, David, and I think the important thing there, given his history, that needs to be fully excised, and it needs to be excised on block. So he needs a conversation about coming back and having an ASD of that, and it's not going to be easy with the scar tissue there. It's not going to happen today, I don't think. But it looks
definitely not going to happen today.